Welcome to this presentation about observation post-vaccination. This video presentation aims to equip you with the knowledge and skills to confidently observe clients in the observation area following their vaccinations. It will help you to know what to look out for, how to assess any problems that arise, and how to manage urgent reactions like anaphylaxis. We will look at the following aspects during this session: a short introduction, being prepared, observation timeframes, how to recognize signs and symptoms, assess and manage problems like a client who feels faint, a client who collapses or develops anaphylaxis, or other allergic reactions. And lastly, we will take a look at reporting forms that need to be completed. Why do we need to observe clients after their vaccination? It's very reassuring to know that most people will have an uncomplicated post-vaccine experience. Very few people will have a serious problem. The incidence of anaphylaxis post-COVID-19 vaccination is less than 5 cases per million doses administered. This means that you're more than likely to have a rather uneventful time in the observation area. However, if a client does experience a severe reaction to the vaccine, it's usually soon after administration, usually within 15 minutes, and we're going to help prepare you for this. First up, be prepared. At the start of your shift, check that you have everything you need in your emergency kit. There should be a checklist in the kit that you can check your medications and equipment against. Check that you have 5 adrenaline ampules, IV fluids, a salbutamol inhaler, 2 promethazine ampules, 2 hydrocortisone vials with sterile water for injection as diluents. Then check you have enough needles and syringes, an IV giving set, adhesives, spacers, and blood pressure and SATs monitoring. It's useful to familiarize yourself with these items before you find yourself in a potentially stressful situation. All vaccine recipients should be advised to wait at the facility for at least 15 minutes following their vaccinations. If a client reports a previous severe allergic reaction to any substance, it is advised that they should be observed for longer, usually 30 minutes. How do we go about recognizing signs and symptoms? What are we exactly observing for? Essentially, we're observing for adverse events following immunization, which are commonly known as AESI. And since we're observing the client straight after vaccination, we're observing for immediate reactions. These immediate reactions can be stress-related responses, like fainting, or they can be hypersensitivity or allergic reactions, and these can be serious anaphylactic reactions or self-limiting reactions. Anaphylaxis is a severe generalized allergic reaction. It is characterized by rapidly developing life-threatening airway, breathing, or circulation problems, and is usually associated with skin and mucosal changes too. How do we go about recognizing the symptoms and signs of each of these? Let's start with fainting, as this is likely going to be your most commonly encountered problem. This vaccination context may result in a common faint known as an emotional vasovagal syncope. Let's break down this term to see what causes this. In some, intense emotion, like the response to pain or fear or a medical procedure, may trigger an overreaction of response pathways in the body. Vaso refers to blood vessels, and here they are dilating. Vagal refers to the vagus nerve, which slows the heart rate. Together, this dilation of blood vessels and a slowed heart rate will result in a sudden drop in blood pressure. This means a sudden reduction of blood flow to the brain, which causes a brief loss of consciousness, which is known as syncope. Anyone can experience vasovagal syncope, but it tends to be more common in young adults, and it happens to men and women in equal numbers. So what symptoms can we expect? A client may complain of the following before they faint: lightheadedness, a feeling of suddenly being warm or cold all over. They might start to sweat. This is often noticeable around the face or the neck. They may complain of palpitations or an irregular heartbeat. They may complain of nausea or abdominal discomfort. Sometimes they may report visual disturbances such as blurring, that can lead to a darkening or a whiteout of vision. Some may report reduced hearing or hearing unusual sounds like a whooshing noise. Onlookers may notice the client becoming visibly pale or losing color in their face. What should you do if a client feels faint? Ask the client to lean forward with their head between their knees or lie down flat for several minutes until they feel better. Loosen tight clothing, undo buttons around the neck, loosen a tie or a tight belt. Apply a cool cloth to their face or neck, and calmly reassure the client. Explain why they might be feeling faint. So what happens if the client actually collapses? Whether the underlying cause is a fainting episode or the result of a severe anaphylactic reaction, the initial management is the same. Whilst moving towards the client, call on any available colleagues to come and help. Position the client on their back and raise their legs. This helps to restore blood flow to the brain. Check to see if the client is responsive. If the client is unresponsive, check circulation, then airway and breathing. Feel for a pulse in the neck for up to 10 seconds. Check the airway by placing one hand on the client's forehead and gently tilting their head back, whilst using the first 2 fingers of the other hand to lift their chin. Next, check for breathing by watching for the rise and fall of their chest and listening for breath. Spend no longer than 10 seconds doing this. If the client is unresponsive and is in cardiorespiratory arrest, meaning they are not breathing and have no pulse, start CPR immediately. Further details of CPR can be found in the PAC Adult Clinical Tool. If the client is unresponsive but is breathing and has a pulse, rapidly move on to assessing what the most likely underlying cause for the collapse was. You are essentially wanting to know whether this client has collapsed because of a fainting episode or if they've collapsed because of an anaphylactic reaction. How do you do this? Start by asking a few simple questions. How long is the loss of consciousness lasting? Is it relieved by lying the client down and raising their legs? When did the collapse occur exactly? Was it suddenly around the time of injection? What are the vital signs showing us, particularly the pulse and blood pressure? And are there any other telltale signs or symptoms like a rash or swelling that may help us with a likely diagnosis? The fainting episode is more likely if the collapse occurred suddenly at the time of injection, either before, during, or immediately after. If the loss of consciousness is short, usually around 20 to 60 seconds, and often relieved by lying the client down and raising their legs. If the client's blood pressure normalizes quite quickly, and if the pulse is relatively slow or normal, and if there are no other obvious signs or symptoms like a rash or swelling. How do you manage a fainting episode? There's no specific treatment. It's a self-limiting condition, meaning it will get better on its own. Similar to managing the client who's feeling faint, loosen tight clothing, apply a cool cloth to his or her neck or face, calmly reassure the client, explain what has happened, and assure them that they will be all right. Check for any other injuries they may have sustained whilst falling. Stay with the client until they are fully recovered. The client may remain lying with legs up until they are feeling better. If they have not eaten for 6 hours or more, give them some fruit juice or similar to sip. Suggest the client contact a friend or a family member to assist with getting home, and advise the client not to drive. Refer only if concerned about a head injury, they're known with a heart condition or any other serious illness, or they are experiencing unusual symptoms such as chest pain, shortness of breath, confusion, blurred vision, or they are having difficulty talking. Anaphylaxis is most likely if the collapse occurred 5 to 10 minutes or longer after the injection. If the loss of consciousness is not brief and is not relieved by lying down and raising legs. If the blood pressure is low, usually below 90/60, and remains low, with a fast pulse, usually more than 120. If the client has any other telltale symptoms or signs, or is complained about these before collapsing, like itch, rash, swelling, difficulty breathing, wheeze, stride or cough, abdominal pain or nausea. Let's learn more about anaphylaxis. and how it and other allergic reactions may present. Anaphylaxis is not always easy to recognize clinically, as presentations are often variable. They include the following: skin and mucosal symptoms and signs, which occur in up to 90% of episodes, and include itching or generalized hives or urticaria, swelling most often around the eyes, lips, tongue, face, or hands and feet, widespread flushing, and then mucosal involvement, which overlaps with the respiratory system symptoms. There may be nasal discharge, nasal congestion, or sneezing. There may be hoarseness or a change in voice quality. There may be a sensation of throat tightness or itching of the throat or ear canals. There may be stridor, which is upper airway obstruction. There may be shortness of breath with low sats. There may be wheeze or a cough, and there may be trouble swallowing or even drooling. Cardiovascular symptoms and signs, which occur in up to 45% of cases, include low blood pressure, dizziness, weakness, collapse, chest pain, or palpitations. GIT symptoms and signs, which also occur in up to 45% of cases, include nausea, vomiting, diarrhea, cramps, or abdominal bloating. So how do you know when to treat as anaphylaxis? Treat when symptoms and signs are generalized. This is usually when 2 or more body systems are involved, but could be if a client has generalized urticaria involving the whole body. Treatment is also indicated when signs and symptoms are serious or life-threatening, even if only a single body system is involved. For example, if a client has hypertension, respiratory distress, or significant swelling of the tongue or lips. It's important to stress that intramuscular adrenaline is safe, and when in doubt, should be given, even if it means you treat a few less severe reactions in the process. Anaphylaxis is variable and unpredictable. It may be mild and resolve spontaneously, or it may be severe and progress within minutes to respiratory or cardiovascular compromise and death. At the onset of an anaphylactic episode, it's not possible to predict how severe it will become, how rapidly it will progress, and whether it will resolve promptly and completely or not. Anaphylaxis also appears to be responsive to treatment in its early phases. Because of these variables, it's important to give intramuscular adrenaline early to prevent the possible progression to a life-threatening situation. Remember, the order of the steps presented next are designed for a single staff member. If several staff members are available, multiple actions should be undertaken at the same time. Lie the client down and raise their legs. If they have severe stridor, however, rather sit them up, leaning forward. If they are vomiting, sit them up halfway, but raise their legs. Call for help. Ask a colleague to inform their supervisor and doctor if available. Ask the colleague to call the emergency medical services and report a suspected anaphylaxis. Give adrenaline 0.5 mL of a 1 in 1,000 solution via intramuscular injection into the mid-outer thigh immediately. Repeat this every 5 minutes if needed. Most clients will respond to 1, 2, or at the most 3 doses. Insert an IV line and give sodium chloride 0.9%, 1 to 2 liters IV rapidly, regardless of the blood pressure. Then check the blood pressure. If it is less than 90/60, give further IV fluids until the systolic blood pressure is over 90. Stop if breathing worsens, as this may indicate fluid overload. Give 100% face mask oxygen if available. If persistent wheeze or difficulty breathing despite adrenaline, also give salbutamol 2 to 3 puffs via a spacer. Repeat as needed. If severe symptoms or if known asthma and wheezing persists after anaphylaxis signs or symptoms have resolved, give promethazine 25 to 50 mg IM and hydrocortisone 200 mg IM or slow IV. Please note that these are not first-line treatment priorities and should not be given ahead of adrenaline and IV fluids. All cases of anaphylaxis should be referred. It's important for both the client and the vaccine program to try and confirm the diagnosis of a vaccine-related anaphylaxis. We do this by taking blood to test tryptase levels. Immune cells, called mast cells, release histamine and tryptase when they are activated. Tryptase levels are normally undetectable in a healthy individual with no recent allergic reactions. These tests are usually done at hospital level, but they are time sensitive and should ideally be done as soon as possible after the reaction starts. So if delays in referral are expected, blood can be drawn into 2 yellow-topped tubes and sent with the client. If a client presents with a rash only, with no other associated symptoms, and the client is well, monitor this client for longer to ensure no other concerning symptoms develop. If able, discuss these cases with a doctor. If no other symptoms develop and client remains well, it's likely to be a pseudo-allergic self-limiting rash, which may respond to oral antihistamines. Advise to seek urgent care if any of the following develop though: swelling of the face, lips or tongue, difficulty breathing, abdominal pain, nausea or vomiting. How do you report these events? There are 2 forms that you may need to know about. The adverse events of special interest, known as the AESI for short, and the adverse events following immunization, known as an APHI form. It's also worth now to know that there's also a mobile app called the Med Safety app that uses the same format as these paper-based forms to report these events electronically. Adverse events of special interest refer to a list of pre-specified medically significant events that may potentially have been caused by the vaccine product. These are listed on the form and include many things like anaphylaxis, thromboembolism, convulsions, even Guillain-Barré syndrome. In our context, however, where we are observing for immediate adverse events, it's likely that you will only need to fill in this form if you've had to manage an anaphylaxis case. Let's familiarize ourselves with the forms. On page 1, there is a section for the client or vaccine recipient's details. There is also a section where you have to fill in your own details. Section B asks you to fill in the date and time of the event. Then tick the type of adverse event you are reporting. Next, there is a space to describe the signs and symptoms as they happened. Next, if you're able to, record the client's past medical history, including any similar past reactions, as well as medications. Section C on page 2 then asks if the AESI caused death, hospitalization, disability, life-threatening event, and gives you tick box options. And similarly, what the outcome at the time of reporting was the recipient recovering, fully recovered, not recovered, etc. Section D of page 2 asks for information about the vaccine itself, like the trade name, the manufacturer, the batch number, etc. The bottom of this section is not applicable as it's for vaccines other than COVID vaccines. Section E is for the first decision-making level to complete, as is Section F, which is to be completed at national level. And that's it. Notice the email address at the bottom of the form to which you email the form, copying in the EPI, District Surveillance Officer. Fill out this form for other immediate adverse events like fainting. The main focus of this form, however, is to report adverse events that most commonly occur within the first week after vaccination. All the same, let's zip through it so you know what's in there. Similar to the AESI form, there's space for the recipient's details as well as your details. A section for the vaccine information, as well as the date and time the event started. It then has a tick box section to complete for minor local reactions, meaning at the site of injection, as well as a section for minor systemic reactions like fainting, mild headaches, body aches, and low-grade fevers. Page 2 has sections for the severe local reactions and systemic reactions. It has a section to describe what the concern is, and a section to report any other similar APHIs, if there have been any. Then, similar to the AESI form, it goes on to ask about the client's past medical history, including any other similar reactions, as well as medications. If the APHI caused death, hospitalization, disability, etc., what the outcome at the time of reporting was, like recovering, fully recovered, etc., and then the same 2 sections reserved for the decision makers. You will note that there is the same email address details for where to send the completed forms. This brings us to the end of this presentation. I hope you have learned more about being prepared, as well as about what to look out for, how to assess and manage a faint, a collapse, anaphylaxis, and isolated rashes, and how to go about reporting these. We'd like to take this opportunity to acknowledge your important role in this process. Please help us to protect you by getting vaccinated yourself if you haven't done so already. Thank you for your part in serving the people and helping the health system to work well. You are greatly appreciated.